సార్ కాల్ చేస్తాం సార్ స్టార్ట్ చేయమంటే చేస్తాం. వచ్చారు అందరు మన వాళ్ళు? ఏం సార్ గురుగారు అందరూ వచ్చారా?
జాగ్రత్తగా ఉండండి. ఒకవేళ మీకు తెలియని నెంబర్స్ నుండి సిమ్ డియాక్టివేషన్, ఎలక్ట్రిసిటీ డిస్కనెక్షన్, కేవైసీ అప్డేట్ లేదా మీ బంధువులు జబ్బు పడ్డారు తొందరవచ్చు. ఇలాంటి సంఘటనలు జరిగిన వెంటనే నేషనల్ సైబర్ హెల్ప్ లైన్ 1930కి రిపోర్ట్ చేయండి. ప్రజా ప్రయోజనార్థం జారీ చేసిన వారు హోం మంత్రి. Your call has been forwarded to voicemail. The person you are trying to reach is not available. At the tone, please record your message. When you have finished recording, you may hang up.
Sir, can I start the seminar, sir? General clerk. ఏం సార్ స్టార్ట్ చేస్తామా? 9597 అయితే స్టార్ట్ చేయాలి. దట్ ఈస్ ద డిక్టమ్. ఏం శ్రీధర్ స్టార్ట్ చేస్తాం? సార్ స్టార్ట్. స్లో సార్ డోంట్ బి టూ ఫాస్ట్, రీడ్ స్లోలీ.
Good morning, sir. Today is a topic about a new surgical technique of intramedullary nailing of abnormally bowed atypical femoral shaft fractures. This is the new surgical techniques of abstract taken from Singapore hospitals, received on 2019. Sir.
Can you read the abstract, if you don't mind?
Abstract: the treatment of atypical femoral shaft fractures with abnormal bowing provides a unique challenge for surgeons. Whilst intramedullary fixation of atypical femoral shaft fractures affords both mechanical and biological benefits, the mismatch between standard intramedullary devices and the abnormal femoral bowing in these patients make this method of fixation challenging for the surgeon.
Sir, good morning, sir.
Morning, start.
Okay, sir, start.
The purpose of this manuscript is to illustrate the evaluation of our surgical technique through a series of 4 patients. The critical factors we identified include lateral positioning of the patient for reduction, the use of a piriformis start nail, and an entry point that was made anterior to the in the sagittal plane and lateral in the coronal profile. This technique was easily replicable, facilitated more anatomical reduction, and aided in avoiding complications.
So you are using the lateral position or supine position?
Lateral positions.
Not
Not on traction.
No on fracture table.
Not on fracture tables.
Only lateral position. Yes.
So introduction: intramedullary surgical fixation of atypical femoral shaft fractures provides mechanical and biological advantages. However, a discrepancy exists between the radius of the curvature of standard femoral intramedullary nails designs and lateral and anterior bows of femurs, thus leading to the potential complications of cortical perforation and fracture angulation. This problem is aggravated by the presence of pronounced abnormal femoral bowing in both sagittal and coronal planes, known to be present in multiple ethnicities. Whilst several authors have innovated techniques to avoid these complications, has identified a unique and replicable solution for this challenge. The new surgical technique: patient is placed in the lateral decubitus position without a traction device. Bolsters are placed opposite to the apex of the natural lateral bow to aid in reduction, whilst manual traction is performed. The use of the bolsters at this point facilitate the closure of the medial gap between the fracture fragments, and it acts like a fulcrum. Reduction maneuvers in traction devices are avoided to reduce the linear vector created by ligamentotaxis that has the propensity to overcorrect and straighten the femur into a non-anatomical position. So in image A, this is the femur aligned in traction table. So we will achieve a non-anatomical reduction. In B, this is the without a traction table, and we applied a bolster as a fulcrum. We achieved a anatomical reproduction, anatomical reduction.
Which side you are using the bolster? Medial side, lateral side?
Medial sides. Upon achieving the anatomical reduction of the femur, the entry point of the nail is identified in both sagittal and coronal planes. In the sagittal plane, the entry point anterior to the midline is chosen. Consequently, when the anterior bow is more pronounced in abnormally curved femurs, the greater the risk of fracture angulation to accommodate the intramedullary device and anterior perforation. Engaging the sagittal entry point anterior to the midline facilitates a trajectory aiming posteriorly. This allows adherence of the nail to the posterior cortex of the femur and therefore reduces the risk of anterior perforation and fracture angulation. So in image A, normally we will entry in the midline, sir. This is the midline, and here we entered in a sagittal plane anteriorly, towards anteriorly. In in image B,
No. Here there is 2 points. When you talk about intramedullary nail, whether it is a cephalomedullary nail or standard interlocking nail.
cephalomedullary.
You are talking about cephalomedullary or both?
Cephalomedullary nail.
Only cephalo. But you are showing a very cephalomedullary nail. It is interlocking nail. Image. You are showing the intramedullary nail.
Plane.
Mari?
Plane, sir.
Cheppandi. Read.
In B, depicts the ability of the nail to negotiate the anterior bow of the femur during insertion. And in C, shows the natural tendency towards anterior, towards posterior, sir. And the posterior entry point in the bowed femur.
So the entry point is more posterior.
More posterior.
Yes.
Normal, sir. In this is normal. In bowed femurs, if we entered in a normal piriformis fossa, midline, the medullary device hitches to the anterior cortex.
There may be iatrogenic fractures. Angulation.
So we will take the entry point anteriorly, sir.
Anterior. Entry point is going through the posterior 1/3. Posterior. Yeah, that is standard. Ade చెప్పడం B. Yes.
So that is why we are erring more anteriorly on the sagittal plane, and on the coronal plane we are taking the entry point little laterally.
Yes, that is true. No. When you take the piriformis entry point and medial to the piriformis, so the ideal entry point for ILN is piriform fossa. Whereas when I come to the cephalomedullary nail, the entry point is just medial. And we have to divide the posterior part of the GT into anterior 2/3 and posterior 1/3. So where is your entry point?
Medial to the greater trochanter.
Medial to the greater. More anterior, more posterior.
More anterior.
More anterior. At the point. That is the point. Yes, sir.
Similarly, similar to the sagittal entry point, the aim of the coronal entry point is to avoid the lateral cortical perforation. Hence, lateralization of the entry point would facilitate adherence to the medial cortex and negotiation across the lateral bow. Finally, the effect of this entry point on reduction was enhanced by implant choice of anterograde femoral piriformis start cephalomedullary device.
That is a final effect. Yes, sir.
With the use of the piriformis start implants with the trochanteric entry, the stator nail is able to adhere to the medial cortex to a greater context. In contrast, if the trochanteric start device is used, the medial aspect of the device may perforate the lateral cortex distally due to the proximal angulation of the nail. Alternatively, it may result in fracture angulation in the coronal plane to accommodate the intramedullary device. This is the anteroposterior view. In A, we entered into the femur shaft by trochanteric entry. In B, this is the trochanteric start device and lateral entry. In C, this is the piriformis start device and medial entry. And in D, piriformis start device and lateral entry in the greater trochanter. So in B, the trochanteric start device and lateral entry, reaches to the lateral cortex, lateralization. And in C, piriformis start device, normal piriformis entry and the medial entry, it reaches to the posterior cortex. And in piriformis start device and lateral entry, it negotiates the bowing. So case series, sir. 84 years female with severe osteoporosis, right femoral shaft fracture. Based on methods of Flassam and Chang et al., her contralateral femur was used to measure anterior and lateral bowing. Her anterior bow was calculated to be 18.9 and lateral bow to be 20.4. And surgery was performed. The surgery was performed on a traction table to facilitate reduction.
Now you are using the word traction table. Kada?
Examples.
Ade example. You said the lateral decubitus position. Now you are talking about traction. So now tell me what is the main difference between the fractured traction table versus lateral decubitus position?
Non-anatomical reduction.
Huh?
Non-anatomical reduction while using traction table.
So which is more advantageous?
Without a traction table.
Without a traction table. Okay, but in this case you are showing the traction table.
Failure, sir. The patient positioned on the traction table to facilitate the reduction. 380 mm in length and 13 diameter. Trochanteric start intramedullary device. Midline sagittal and coronal trochanteric entry point. Normal anatomical restoration of the femoral bow was defined within 5 degrees of the contralateral rim, anterior and lateral bow. So this post-operative radiograph shows non-anatomical reduction with a difference of 7.2 degrees in the lateral bow and 8.8 degrees in the anterior bow. Thus, there is an excessive straightening of the right femur. Straightening of the right femur and non-anatomical reduction.
So that non-anatomical reduction, what you are showing, can be corrected, better corrected in a traction table. We could release the traction, you continue it manually, milky, it comes out. Whereas in a lateral decubitus position, you can't correct it. The milky procedure is very difficult and the C-arm position, everything is very difficult. With your lateral decubitus position, lateral, left up or right up. But here is control is better with the traction table, whether C-arm movement or controlling, you can see better way. And you can do the reduction also before distal interlocking bolts are applied.
So
better.
Compared to the contralateral femur, this femur has over straightened, sir, due to the use of traction table. So 72 years female on bisphosphonates, left atypical femoral shaft fracture with complaining of prodromal anterior thigh pain for 3 months. Preoperative radiographs, lateral bowing of 16 degrees. She was positioned on the traction table for surgery. Due to the severe anterior and lateral bowing of femur, a piriformis entry point device, 320 mm length and 11 mm diameter. The entry point used in the coronal plane was lateral entry, greater trochanteric entry, to hinge upon the lateral cortex of the femur, and sagittal entry, more anterior entry point, used in the prevent anterior cortex perforation. So in post-operative radiograph, the anterior bow of the femur was anatomically reduced with a change of only 1.8 degrees with an anterior and lateral midline. Anterior to midline sagittal entry was used as compared to the previous case study. There was again a non-anatomical reduction with excessive straightening of the previously bowed femur in the coronal plane due to traction utilized during the procedure.
So excessive traction is not advisable.
Not advisable.
So you have to check. So in both AP and lateral view, you should be center of the medullary canal. And you have to see the not only the fracture reduction, but also the entry point and fixation. Everything all plays a role. Yes, sir.
73 years female, right atypical femur fracture, prolonged bisphosphonate use, and evidence of lateral femoral midshaft cortical thickening. A plan for prophylactic intramedullary fixation for her left femur. Patient was positioned in the lateral position. A piriformis start device of 380 mm length and 12 mm diameter was used. The coronal entry was utilized was greater trochanter lateral side and the sagittal entry anterior to the midline. It's a prophylactic, sir, not a shaft, not fracture. shows the ability to provide cortical perforation during prophylactic insertion of the intramedullary device in an abnormally bowed femur with adherence to the following factors: lateral position without traction, piriformis start device, anterior sagittal entry point, and lateral coronal entry point. The 76 years female, osteoporosis on prolonged alendronate treatment, left femoral shaft fracture. The patient underwent surgical fixation the day after. To achieve the anatomical reduction, the patient was surgically managed by lateral position and not on a traction table. A piriformis device, 320 mm length and 9 mm diameter was used. The coronal entry point was the tip of the greater trochanter, and the sagittal entry point for the intramedullary nail was anterior to the midline. With the combination of factors found to achieve near anatomical reduction of the fractures. In addition, the entry points allowed us to avoid cortical perforation. The post-operative.
Still only one interlock.
Lateral position without traction, piriformis start device, anterior sagittal entry, and lateral coronal entries. Discussion. Current.
All these fractures are atypical fractures.
Yes.
Atypical fractures, and they are not segmental fractures. They are also important. So segmental fractures are excluded. Ante kada? Yes, sir. Suppose a segmental fracture is there. You want to use a traction table or a lateral decubitus, left up or right up position. Segmental fracture.
Compare with the lateral opposite.
Compare with opposite. What?
Opposite femur. We should calculate the bowing. If bowing is there, sir. If bowing present.
Segmental fracture.
Segmental fracture, no traction.
Not the question. When it is segmental fracture, where is the need? How do you calculate the bowing? No. Already gone. So what is the importance of osteotomy? At the level of osteotomy, you can correct the angulation, you can correct the rotation, you can correct the displacement. Anything can be. So God nature, segmental fracture already means gone. So all things are gone. So you have to correct them in position, anatomical reduction, achievement with the nail for early mobilization and better functional outcome results. Yes, sir.
Discussion. Current designs of intramedullary fixation devices for femur fractures have an angle of curvature disproportionate to the geometry of the physiological bowed femur. This issue is especially evident in the Asian population, which is known to have markedly bowed femurs. Whilst nails with a shorter radius of curvature are being developed, these options are not universally available. This has served as the premise for the development of this technique to circumvent possible complications such as cortical perforation and fracture angulation in these abnormal femurs. Nirav et al. Described this technique of using the starting guide pin as a blocking screw for the insertion of the guide wire. In surgical experience, found that whilst this was indeed successful for avoiding anterior cortical perforations, attempts to centralize the nail in distal fragment often led to straightening of the femur and a non-anatomical reduction. Similar to our technique, Kem et al. Showed in their study that the use of straight nail with a modified entry point through the tip of the greater trochanter result in less deformity and improved healing. Using three-dimensional printed models, Park et al. Recommended the nail with the smallest radius of curvature, smallest diameter, or the opposite side of the lateral bended nail. While this may prove effective, we are concerned that the use of smaller nail may in fact compromise the rigidity of the nail. This paper also mentions the possibility of using a straight nail with a greater trochanteric entry to overcome the lateral bowing that is in the experience. Through the combination of the piriformis start intramedullary device with a lateral position for reduction, anterior sagittal and coronal lateral entry points, we were better able to achieve the anatomical reduction with the avoidance of cortical perforation. Thus, we suggest this novel and easily replicable technique to avoid in the intramedullary nailing of patients with abnormally bowed femurs.
So all our cases are bisphosphonate and osteoporosis. No Paget disease.
No
Paget disease.
Not taken, sir. Singapore.
అది తీసే అక్కడ మట్టి అదే ప్రాబ్లం వస్తుంది. లేదు ఆ కుర్చీ తీసేసి వేరేది. ఎస్ నెక్స్ట్ సింగపూర్
2019.
టైటిల్ Was there any difference in the rate of healing of the fracture with anatomic reduction and non-anatomic reduction?
Yes, better improve.
The duration, no? Was there any chance of non-union because of non-anatomic reduction? Any data on that?
No data, sir.
What it
Only
is with non-anatomic reduction, the fracture is, what does it matter?
straightening of the femur, sir.
So what will be the, is there any change in the gait,
Lengthening.
lengthening? So how to overcome that?
I-
If it is lengthening, you can do shoe rise to the opposite leg.
New.
It hardly lengthens by a few millimeters or not more than 1 centimeter. Okay. Some research is done, it is fine. How far it is practically applicable, and does it really require such a, the only thing is prevent the cortical penetration.
Penetration.
Most important.
Iatrogenic fracture, iatrogenic fracture, and sometimes it may not be.
X-rays.
If the distal fragment is not properly reduced, you can go for a lengthening of the limb. Yeah, we can solve.
Sir.
Especially in external rotation.
So these are the cases from Unit 2, sir. So 55 years female with closed tibial plateau fracture of left leg. Sharska type 4. Both medial and lateral condyles are involved, sir. Only lateral condyle there is split. The medial condyle is totally yours. These are the CT images. Only split, sir. Lateral. No depression, sir. No, sir. The medial condyle, sir. Medial condyle, sir. So we done open reduction internal fixation with plating for TBS, buttressing. So 50 years female with 3 weeks old tibial plateau fracture of left leg. So only medial condyle avulsion is there. That's the CT images. Only medial condyle is involved. We done open reduction internal fixation with plating for left tibia and with bone graftings.
You were there assisting this case.
Yes, sir.
What were the fracture fragments, margins of the fragment? Are they sclerosed, rounded off,
No, sir.
or fresh?
Sclerosis started, sir.
Did you freshen the
Yes, sir. Freshen, sir.
freshen?
Freshen, sir.
Because the X-ray shows that already margins are sclerosed.
Yes, sir.
The margin is not irregular like a fresh fracture. So had it been left like that, probably it would have ended in non-irregular.
No,
There might have been
smooth.
surface on the fragments, not
Yes.
like a medullary bone.
No.
Did you scrape that?
Scrape and we drilled holes.
Drilled out.
Yes. So 72 years males with intertrochanteric fracture of left femur, sir. We have done closed reduction interfixation with proximal femoral nailing for left femur. Lateral and greater truncated tip of greater. closed distal third radius shaft fracture, sir. Galizzi type. Open reduction interfiction with plating for left radius. Intertrochanteric fracture, 65 years intertrochanteric fracture of left femur, sir. Done PFN for left femur. 71 years intertrochanteric fracture of right femur, sir. Reverse oblique type. Closed reduction interfiction with PFN for right femur, sir. Yes, sir. Anterior and lateral. 71 years. Greater trochanter. Lateral entry, sir. Lateral entry. Yes.
Next.
The previous intertrochanteric, we have used the long PFN.
Yes.
Why you are still insisting the short PFN?
Bowing.
No, not the bowing test, the one before that. Here it's, see, osteoporotic.
65, sir. No.
What is the advantage of long PFN or short PFN? Even though it is a type 1 intertrochanter.
Working. Difference between working.
The working length doesn't matter in the true intertrochanter. Stable fracture. What are the advantages and disadvantages of short PFN and long one? Why can't we use regularly long PFN for every case? Each has got its own advantages, disadvantages. Why do you most commonly prefer short PFN? Why not long PFN? Long PFN prevents peri-implant fractures. Okay? So the working length doesn't matter if it is a stable fracture. Even with short PFN, the stability of fixation will be adequate. Why not long PFN for each and every case?
In case of intertrochanteric fractures.
Any idea, Raghavendra? Common sense. Short PFN doesn't require a freehand technique for distal lock because it has a perfect jig. Because of the sharp length of the nail, the jig will match to the distal holes. Whereas a long PFN, the distal locking is done with freehand. Where you need to use siam, radiation. For 2 screws, at least you will click at least 20 times for centering the hole. So there is no need of radiation for the, except for guide wire. You don't require radiation much for short PFN. Short PFN disadvantage, peri-implant. These are all common sense thinking.
Sometimes the short PFN may land up in varus collapse. Varus collapse. Varus collapse could be chances. Yes, sir.
Good morning, sir. This is a 57-year male with a distal end fracture of right femur with intra-articular extension, Evo Muller, beat 1, sir. Osteop. No, sir.
Nina, Sina.
He, he, sir.
B.
B, sir.
B. No intraarticular extension.
One, sir. Partial intraarticular on this.
Partial artery.
C, sir.
What is A? What is B? What is C?
A is extraarticular, B is partial intraarticular, C is intraarticular, complete intraarticular.
Is it not the intraarticular?
Inter complete, sir. Yes.
Goes through the intracondylar notch.
Yes, sir.
C1, C2, C3.
C1 is simple intraarticular, sir. C2 medial condyle.
Medial C2, as you said, simple articular. No metaphyseal comminution, no articular comminution. C2, no articular comminution, only metaphyseal. C3, metaphyseal as well as
Articular combination.
So there is no articular comminution as far as the X-ray goes.
Yes, sir.
Even
Intraarticular
though you
also.
find a fracture line on a plain X-ray, it is almost always certain that there will be an intra-articular extension, especially at the level of the condyle. Pure supracondylar fractures are rare in adults, not that common like children. Pure supracondylar can happen, but not common. Always, you don't find occult fracture lines here. If you take a CT, then you will be able to
Yes.
address that. Yes.
What is B3 fractures? B3 fractures and B1, B2, B3. B1 is
Lateral condyle. B2 is medial condyle.
B3,
Partial intraarticular with
Comminution.
B3, OFA fracture, OFA fractures. Coronal OFA fracture fractures. What is specifically? Muller's, Evo Muller's classification. Description of it. Yes, sir, go ahead.
This is CT, sir. The intraarticular is.
CTలో తెలుస్తుంది కదా.
Yes, sir.
Zoom.
Which is more informative? Is it the 3D reconstruction or the regular CT in 3 planes?
Regular CT, 3.
Regular, why not 3D? You look as if you are seeing the bone is near to the shape of the bone.
Yes.
Why this regular series of CT are more informative? It gives in all 3 planes, sagittal, coronal, as well as axial. Comminution or the number of fragments will be more vividly seen in the regular CT sections, but not in 3D.
We have done open reduction internal fixation with plating for right femurs.
Medial cortex appears reasonably intact,
Yes, sir.
not much of comminution. If it is significantly comminuted,
Medial
what
plating.
will be the problem and how to prevent the problems?
So, non-union.
So if it doesn't connect, what happens? You can walk on the plane. Plate is so strong.
Peri-implant. Peri-implant fractures.
Walk with non-unions also.
Leading to peri-implant fractures.
Peri-implant.
Implant
Peri-implant
implant
fracture
breakage.
is a phenomena after the fracture healing.
Implant breaks.
Implant break.
Why will it break?
Stress bearing.
Force. Weight and implant. Weight.
Explanation should be like a sentence and in a clear form. There will be varus collapse. There is a medial comminution. There will be varus collapse on weight bearing. Even without weight bearing also, the amount of adductor force acting on the adductor tubercle is so great that even the strongest implant will fail, even without weight bearing, leave alone weight bearing. Okay? The adductors keep pulling the distal fragment where they get inserted, and that causes stress at the implant bone interface. So that starts loosening the implant. If it is a locking compression frame, that is locking edge screws, it delays the collapse. But if it is a regular cortical screws, the implant loosening will be very, very early. So if there is a significant comminution, how to prevent that complication of varus collapse? I have seen many varus collapses with bent plate, broken plate also. Initially the X-ray will be very good, immediate post-operation. How to prevent that complication?
Dual plating.
Medially
Dual
plate.
Dual plating.
So how do you address the comminution? Somebody is mumbling in the back seats. Fibula strut graph will prevent collapse, varus collapse. It not only acts as a very good strut and then prevents collapse. Number two, it is an osteogenic bone. Though it's a cortical bone, over a long period of time, it gets integrated. You may not require a plate also. There is a significant comminution, maybe like C3 or C2. They are the ones which require fibular graft. Over and above that, if it is still grossly comminuted, to maintain the length, in addition to the fibular strut graft, you can also use a plate. So it depends on the amount of comminution. Yes.
Sonia girl with closed distal third shaft fracture of the right femur.
See, this is a supracondylar.
Yes, sir.
You rarely find intercondylar in children.
So we have considered biological fixation, CRIF with K-wire fixation for the right femur, sir. There is no.
Can we avoid surgery in this girl?
We can.
In APVO, it is very well impacted. And in lateral view, it appears to be the anterior cortex is intact. It is almost something like a green stick fracture. It's a 7-year-old
Yes, sir.
girl, very young girl. Want to treat it conservatively? Does it require surgery?
We can apply upon slab also, sir.
Slap will do.
If there is swelling, immediately followed by casting.
Followed by if there is no swelling, because they are relatively undisplaced, except for angulation, they don't produce much fracture hematoma, nor significant soft tissue swelling. Of course, as you said, better to put a slab in the beginning. How to manage conservatively?
So abonic cast. Abonic cast.
You don't correct the angulation. Conservative means don't do anything except
Manipulation and
remove
have to manipulate the
How do you manipulate?
traction by giving traction.
Is there any overriding to give traction?
But the posterior cortex can be aligned straight, sir, by
Anterior cortex appears to be intact.
intact, but posterior there appears like impaction.
What happens if you give traction with one cortex intact? Will it come? Without manipulation, without traction, is there any way by which you can correct this? Is the angulation acceptable? First of all, that is what you are supposed to do. AP view anatomical. The normal tibiofemoral angle is absolutely maintained.
Yes, sir.
If you want, you can take opposite knee X-ray and also compare it with the normal knee joint or the whole limb to know whether there is a increased valgus or valgus or whatever it is. It appears as if the normal tibiofemoral angle is maintained in AP view. It's almost normal. But in lateral view, what is this angulation called? What do you call this deformity?
Anterior bowing.
Anterior
Bowings.
bowing. What is it called in terms of angulation?
Procurvatum.
The convex side of the deformity is described as the angulation. Okay? It is anterior angulation. Does she require anesthesia?
For manipulation,
Is
this
it
requires.
acceptable first of all?
Sorry,
How much of angulation is there at the fracture site? Just by eyeball checking.
30 degrees, sir.
So ideally, Brownian method will be made use of. Yes. Say 30 degrees upright. Is it acceptable? If it malunites in the same position, it is going to unite. Whether you immobilize or not, in 3 weeks, if the fracture becomes sticky, and the patient starts maybe walking at the end of a month. What happens if it unites in this position only?
Mild shortening might be later.
Shortening, okay. The angular deformity may cause mild shortening. Yes. And sometimes the metaphyseal fractures they overgrow because of the increased vascularity at the nearer to the growth plate in young children. That may compensate for the shortening by the fracture displacement or impaction. There is impact, you can see
Yes, sir.
the width of the proximal fragment and the distal fragments are varying. That means there is impaction. They are all stable fractures. Even if you don't immobilize also, till the pain subsides, child will not be able to walk because of pain. There is a protective mechanism. What happens? What will be the problem? As you said, shortening may be there, which may be hardly noticeable and which will be compensated by increased rate of the growth because of the increased vascularity around the
Fracture, sir.
growth plate. There is a natural phenomenon. Will there be any other problem apart from limb length discrepancy? Will there be any obviously cosmetic deformity? That may be one because there is anterior
Angulation.
cosmetically because it will be covered under the garment, it may not be noticeable. Will there be any other problem? To the extent of the angulation, the extension of the knee will be limited because the arc of motion may be completely normal. at the level of the joint. Since there is a deformity, she will not be able to do full extension to the extent of the angular deformity. So if it is 25 degrees, the extension will be lost by 25 degrees. And while walking, the knee may not get locked and they tend to fall. Hyperextension is the one which prevents falling down while they are walking in during normal gait. Quadriceps will hold the knee joint stably
extension.
and it prevents buckling. If there is a flexion deformity, it tends to buckle. So it produces, though not at the the true joint, it is a metaphyseal fracture which can produce limitation of extension and the child will walk with a flexion. These are the mechanics at the knee joint. Okay. So this much of angular deformity may not get straightened up. It may get corrected by linear growth to the extent of maybe 10 to 15 degrees, may be corrected by natural remodeling of angulation, but not to the extent of 25 degrees also. We will be left with some more deformity. So how to treat this fracture? Any idea? Exam going on Anta?
No, sir.
Yes, somebody come forward. Okay. So it can be managed very easily without surgery, because surgery has got its own risks. Okay, and of course the routine surgical complications are infection and then knee stiffness. We have seen so many cases of knee stiffness with this type of KYs, because there will be denodizing effect of all the projecting vice at the joint. How much angulation is corrected? Is it anatomical?
No, sir. Still 5 degrees.
Okay. So this can be managed without anesthesia to correct the angulation by a procedure what is called as a wedging of the plaster. Now what is
Wedging.
wedging of the plaster? No idea.
No, sir.
So put the cast, don't manipulate the fracture. Put a snug fitting POP cast, then the edema subsides maybe in a week or so. If you leave it for 2 weeks, already the callus starts forming, more so because it is a metaphyseal fracture. They heal faster, and moreover in children. So put a long leg cast up to the groin to toes, and then cut the POP in a half circle posteriorly, posterior half of the circumference of the plaster at the level of the angulation. So mark it and then cut posterior half of the plaster circumferentially and try to break it and then bring it anteriorly, bring the limb anteriorly, so that to the extent of what is the angulation, you can bend it and then fill the gap that is created by cutting the plaster so that it doesn't collapse again. You put some stick-like thing or a POP that is reinforced in the gap, and then take a check X-ray and see whether the angulation has been corrected or not. It doesn't produce much pain because you are not trying to manipulate it. It's a gentle correction of angulation. Child may cry a little bit, but it is relatively painless, and you are not going to disturb the mediolateral alignment of the fracture site. So in during this procedure, you are also likely to break the anterior cartilage, which is ideal. Otherwise, again it may get recoiled, and the fracture memory will be there during the fracture healing, and it again tends to go back into its original angulation. That is called fracture memory. So whenever you find a green stick fracture, you have to make it into a complete fracture. Otherwise, it gets re-angulated within the cast, however snugly you apply it. So this is called as a wedging of the plaster. It's a very simple technique, easy to do. Child will not have much pain, and least expensive. You can avoid surgery in this case 100%, provided you know how to do this so-called wedging technique of the plaster. Okay.
When do you want to remove the KVS in this case?
We are considering 4 weeks, sir.
Exam going. ఎవరు మాట్లాడలేదు వెడ్జింగ్ ఆఫ్ ప్లాస్టర్ తెలుసా? Nobody is coming out.
Yes. When do you want to remove the KVS?
After 4 weeks, sir.
4 weeks. You want. What is the age of the child?
7 year.
7 years, 4 weeks. Remove చేస్తాం. What is the formula? Up to 10 years. 1 year, 1 week plus 2. That is the fundamental principle. Up to 10 years. 1 year, 1 week plus 2. And even 7
plus 2.
9 weeks. That's the principle. Up to
Okay.
10 years. We
What
have
will
10
be
years
the
of
other
formal level
complications? What will be the other complications of this type of fixation? Leave alone the so-called all routine complications of anesthesia and infection.
If
all those things.
if the growth plate is damaged, then we
Then what happens? Will it not cause damage?
passes through the KVS passes through the growth.
So will it not cause damage? What happens if there is a growth plate damage?
Restriction.
Growth gets restricted, sir. Growth restriction.
Growth restriction. Premature fusion.
Sir.
And what happens if both sides KYs, the damage to the growth plate is has been seen? What is going to be the deformity?
The affected limb will not be
Is it like stapling?
no,
Is it similar to stapling where you modulate the growth? In stapling,
Kinds.
you don't damage the growth plate. You only control the growth. Here, you are going to cause damage. The amount of damage done by 1.5 mm KYS is relatively insignificant, but sometimes it is quite possible that there may be union between the metaphysis and the epiphysis, and the rest of the growth plate, what is not tampered, keeps growing, and at the point of junction at the metaphysis, at the entry point of this KYS, there may be premature growth arrest. So that may cause distortion of the epiphysis. Epiphysis may get distorted. There may be malalignment of the joint. What do you call that? Suppose if there is a growth arrest which is going to cause deformity in the epiphysis. What is the management? If you pass through, that is highly likely. Management of so-called premature fusion due to implants. Can you do anything to prevent that future complication?
For
Backbenches.
to maintain the symmetry, we have to do stapling for the opposite contralateral.
So you tamper the normal limb. You want to make the chain shorter.
To better than being asymmetrical.
That is better. Is there any better way to prevent that premature growth arrest? Growth arrest has already taken place. Can you undo that by any procedure at the site of the problem? What is epiphysiolysis? You have to take CT scans for that to know whether there is a bony bridge, a bar, which is crossing the growth plate. That is the important study, not the plain X-ray. Bony bar can be easily identified on a CT scan. ఎవరు వెనకాల what is the epiphysiolysis, otherwise called as a Langenskiol procedure? You remove the bony bar by surgical excision and then fill it with some soft tissue like fat or gel foam or some other non-osseous material. You can put fat also in there so that it prevents bony continuity. That is called epiphysiolysis or Langenskiol procedure. Okay. Next. There is so much to learn about each and every case. Unless we know, unless we read, we do not know. We have seen a child which was operated for a distal both bones metaphyseal fractures in a small child, in a girl who is known to me by some surgeon in Hyderabad. They have put rush nails, not KYs. Both the bones are fixed by rush nail, and within 1 year she has developed very bad cross union, that is the bony bar, and she started developing a varus deformity, valgus. The radius growth is disturbed, and she started developing manus valgus, very upward deformity, and subsequently the child underwent 3 surgeries for correction of the deformity by a pediatric orthopedic surgeon called as Resha Madhuri from CNC Vellore. She underwent 3 surgeries to get those deformities corrected. But injudicious use of implants. Rush nails should never be passed across the growth plate because they are of considerable diameter. And these children should be followed up and see that they don't develop this complication of premature growth arrest. Very, very important. They are all iatrogenic. But we tend to pass left and right KYs for supracondylar fractures, humerus, and of course these things also. You must follow up this child not only up to fracture union, at least for 2 to 3 years, and see that they don't have all these complications.
70 a female with distal third both bone fracture of the left forearm. She also have a previous history of wrist damage in 30 years back, sir, with positive ulnar. Yes, sir. She also has a positive ulnar variance.
What was that old injury?
It's like
How many years back?
30 years, sir.
30 years back.
30, 30.
At the age of 40.
Yes, sir.
Yes. What was the earlier injury? Was it a soft tissue injury or a bony injury? What was the treatment given at that time?
She in native treatment, sir. She went for native treatment.
Bone setter.
Yes, sir.
Okay. What is your assessment of the previous injury? Was it anatomically united or there was no fracture at all. You only told about the previous history of injury. You are not talking anything about it's a sequelae.
Deformity is present, sir. Like positive ulnar variance is present. Positive ulnar variance. Sorry. And also the joint space is reduced, sir. Between the carpals and.
Which joint space is reduced?
Yes, sir.
So she has arthritis. In which we are studying the joint space. రెండే వ్యూస్ ఉన్నాయి ఏదో
AP.
రేపు లాటరీ
Anterior posterior and lateral కూడా.
Lateral view is a better indicator for joint space in wrist. Okay. Was there any bone injury at all at that time? Because even without a fracture,
So carpal bones.
whatever may be the nature of the injury, they simply do some massaging and put some splintage. Doesn't mean that they always go for a fracture only. No abnormality in the radius or ulna.
Deformity.
Backbenches. కనిపిస్తుంది backbenches. I don't want to comment at all. You look at the alignment of the distal radius, the shaft and the articular margin. Distal 1/3 of the shaft of the radius and distal end of the radius. Is there any ulnar variance, no variance?
Positive ulnar variance.
And the direct flow is what about TFCC, stable, unstable? First, let them speak about the bone. TFCC comes later. The distal end of the ulna is also deformed, but we are not bothered about that much. You always, whenever you think of some fractures around the wrist, you always think of the 4 parameters of the radiological assessment. You are not thinking that in that direction at all. How is the inclination of the distal articular surface of the radius? Tell me all the 4 radiological parameters.
Radial inclination, volar tilt, radial height, and ulnar variance.
Did you think of this? In spite of repeatedly poking, you are never thinking in that direction about this alignment of the distal radius in the wrist joint. What is the purpose of knowing some theory? It should be put to practical application. When it is not being done, it is as good as not learning. Now think of that in all these 4 parameters.
So radial height is reduced. Radial inclination.
This point has been constantly being focused whenever a distal radius fracture is put in the surgical audit.
Morning, sir.
We are not able to think it in those lines. Simply you said that there was a history of injury 30 years back.
Yes, sir.
Was it a bony injury or only simply a sprain or something? For everything they do massaging and put the splintage. Yes, now talk about all these 4 parameters of distal radius assessment.
Radial height is reduced. Radial height is reduced, sir, and volar tilt is.
How is the radial inclination? It is in the APT.
Yes, sir.
Yes.
22,
What is the angle? Radial inclination here.
it's around
Hardly 10 to 15.
15 degrees, around 15 degrees.
Okay, it is reduced by half. Next.
Radial height, it is reduced, sir. And volar tilt, it is in the lateral view. It is
Polar tilt is how much?
lateral ఉంది కదా.
Is it polar tilt or dorsal tilt?
Volar.
Polar tilt.
Which way it's looking?
It is directed towards the dorsally, sir. Face it towards dorsally.
Why are you calling it as polar tilt? You are not looking at the first metacarpal at all. Which is dorsal, which is volar.
It is tilted dorsally.
And it was there in your mind only volar tilt, and as if the volar tilt has been exaggerated.
Okay.
That is there in your mind.
And
Okay.
positive ulnar variance.
Yes. So what was the fracture at that time? That is the final conclusion.
Distal radius fracture.
So what was there before? What was the problem before this injury? This itself is a treatment,
Sir.
probably to some extent. Can you look at the lengths of the ulnar radius?
Yes, sir.
What is it?
Ulnar is proximally migrated compared to that
So
of
what
the
is
left.
that called?
Positive ulnar variance, sir.
So that's a result of what? If it not happened, do you think it's happened because of this injury?
No, sir. It's,
Why? Why do you say it's not? You're right, but why do you say it's not? Look at the
Deformity.
X-ray. See the radius. What is it?
Yeah.
Look at the radius. The radius is almost little angulation, not much of shortening. The ulna shortening and even a little shortening, little overriding, not shortening, but overriding. Still it's prominent here. That means it's from previous injury, not from the current injury.
Yes, sir.
Okay.
Must have had a very badly displaced malurinated polys fracture. So much of dorsal tilt. That was the previous injury.
And of course, probably it wasn't too bad. The function, how was the function before this injury?
She's partially able to do.
How old is she?
She's 70-year-old.
70, so 70 probably. Yeah. So how do you manage this one?
We have done plating for both.
Both. You want to do, okay, radius plating. And for the ulna, what do you want to do? Just plating or anything else?
We can do osteotomy for.
Osteotomy already done.
Even before this injury, might have been having a ulnar head
Prominence, yes, sir.
unduly.
Yes.
Did you ask?
Yes, sir. It's visible. We have seen.
See, quite significant here. Probably limitation of movements, might have pain. And can you say this? But the radial side of the ulna is articulating with the carpal bones. That means it's very long-standing. So what else you can do? So fix this one, and you want to fix this one as well in same position. Not reading. That's a problem. Not studying. Not reading.
Though they know some theory,
Applying. Yes.
practical application.
Anybody?
Problem. When I asked him the same question, what are all the radiological parameters for distal and radius injuries, he is telling all the points, but he is not putting it into application.
Anybody? So we got an opportunity here to correct the existing previous deformity. How do you correct it? Very simple, like not complicated. Orthopedics is not complicated. Common sense. 50% is common sense. See, we said ulna is lengthened. Previous
Shortening
injury.
of,
How can you make it short?
Osteotomy, sir.
Osteotomy is already done.
Broken.
Where else you want to do osteotomy?
So,
If it's something is very long, you want to make it short, what do?
We have to
You want a 60 inches stick is there, you want to make 50 inches. What do?
we have to cut it.
Cut it. Here, cut it. It's longer. Cut it and fix it.
Sir.
Try to align the DRUJ to the extent
To the
possible.
under it, that's all.
You shorten the bone.
Shortening, because you got an opportunity. Fix this one. See how much is after fixing. Check image intensifier. Bring it down and correct it. Excise. Part of it. You want to excise this one or this part? Which one you want? Distal one want to excise or proximal one? I think no. Anybody? Any senior residents? Come to the front. Exam going, come here. Stand here. I didn't see you. All of you come here. This is an examination question. Ah. Come here. Oh, I've not seen it. We should ask you rather than anybody else. Oh, I didn't realize. I would have come. Okay.
Why you are not coming forward?
You're not opening your mouth.
Repeatedly calling you to come and answer.
You don't open, and it will be. So you.
You may be knowing what you should express.
So what do? Which one? We are come to a stage. Which part of the ulna you want to shorten? So you want to shorten this part? No, my question is very straightforward.
Asking which fragment, proximal or distal? Question is very straight.
Which one? Huh? Why proximal part? Ah. No. That's important. Very valid point.
Purchase of the plate on the fragment should be adequate.
So if you shorten this one, you will not have place to put a plate. Becomes too short. So shorten this one. Common sense. That's what I said. Orthopedics is common sense. In examination also you fail by your own mistakes. Not thinking. You before we ask a question, you try to answer. Without you answer the question before we understand the question. And most of the time our answer is within the question. If you ask a leading question, the answer is there. Most of the time it's yes.
So there is an oblique fracture. You are shortening the proximal fragment. What is going to be the contact area of the fractured fragments? You have made a transverse cut in the proximal fragment, but it doesn't have a good contact. 100% contact will not be. Then there may be a gap that is left. In spite of fixation, it may not unite. If it is transverse, you are correct. Here is an oblique fracture. If you make a transverse cut in the proximal fragment, there will be a gap between the proximal and the distal fragment. Chance of non-union are high.
So make transverse, make this all.
Regulate a little bit
Yeah.
in the proximal and a little bit in the distal fragment. Try to make it as transverse as possible. If there is a 75% contact, it's fine, it's going to unite. Okay, next.
Okay, any?
So simply putting X-ray, fixing the plates doesn't make us more wiser. It is a routine craftsmanship.
With this next week only exam. Monday, Tuesday. Yeah. But you have to say whatever. Common things which you know. No bluffing. You should not bluff. There is a chance of 50% right answer, but you will not get 50%. You will be 100% wrong. Be honest to yourself. In the examination, what do we expect you? Whether you're going to be a safe doctor, whether you have willing to learn, whether you're going to change your practice by learning, that's what we assess. We are not expecting you to become an expert. MS degree is to practice as an orthopedic surgeon. It's not to say that you already expert orthopedic surgeon. It's only makes you licensed to practice so that you become good orthopedic surgeon. That should be in your. And most of the time what happens, somebody will tell you the diagnosis. And it's misleading. But that's okay, everybody can understand. It's misleading. If you know the diagnosis beforehand, always is misleading. You miss other points and you will lead to the diagnosis. You only say what is take you or leads you to the diagnosis, which is not right. Should have open mind. Even if you don't know the diagnosis, you should make in a way that you exclude all other possibilities and leading to a same diagnosis or differential diagnosis. Most of the time what happens, you don't sleep night before. You read entire 3 years, try to read entire 3 years in one night, which is not possible. You must sleep, and sleep 1 week before, you should have practiced. Sleep cycle will take about 1 week. So presence of mind is more important. And most of the time it's simple cases, simple answer. We never ask you complicated questions. Always simple questions. We will not intentionally fail you. We are always there to support you, provided you are being honest to yourself. If you don't know, that's it, because you are wasting time. Keeping silence too long is not good. I don't know, sir. Or, yes. Because everybody is there to help you. Nobody intentionally will fail you. But you should know basics. You cannot make mistakes in basic principles like examination of a joint, examination of swelling, examination of a deformity, range of movements, limb lengths, all those things, basic things. And you have to have only one way. There is only one way. There are no two ways of examination. One way, your way. And the treatment, when we ask you, what is your treatment, there is only way. I would like to do this, or this can be done, or that can be done now. Or you can say, sir, this is my first option, this is my second option.
And examiner will be always be pleased if you say the answer what is being practiced in our institute. Then the internal examiner will come to your rescue.
You tell what you've seen. That's what we've been. If something, maybe something treatment which is not common or no, you've not seen, you say, I'm not seen, sir. Because you're not going to practice which you're not seen or done. You're only going to practice what you've done, what you've seen, what you assisted. Okay? But this is classical X-ray. If it is there, probably it will be in the examination. Not now, but similar one. Okay.
Not in this exam.
Maybe. Okay. Next one. Sit down. Sit down.
We have done ORF with plating for left radius and ulnar, sir.
So did you follow the principles what we discussed?
Yes, sir.
Did you shorten it?
Yes. No, sir.
No. Because it's not. Who has done this?
Dr. Jairam, sir.
So you did not discuss beforehand.
He was taken back to the pre-injury status of
Yeah. But ideally should have shortened and probably should have done it. Probably not thought about it. Okay. Next one.
A 39-year-old female with closed 1-month-old olecranon fracture of the right elbow. This comes under Mayo's type 2, sir.
There is no proper
Displaced
lateral view.
non-comminuted.
Both are oblique. No AP, no lateral. Are they lateral?
Not true lateral, sir.
AP? Is it true AP? Is it because of the pain? Why you don't know?
Not able to elbow in complete movements.
We'll ask one of these people. Yeah. You describe the X-ray. Because you're not going to answer after the exam anyway. Is that true? No. Okay, go on. Yeah, both are oblique. Can you see? What can you see? Is there? Fracture, yeah. Displaced, undisplaced. What do you want to do? So why are you worried about the fracture, or something else is more important than the fracture? Extensor mechanism is important. So you're trying to, like patella, you are restoring the extensor mechanism of the elbow. Okay, what was done? Sit down.
So we have done tension band wiring with KVS for the right ulnar, sir. And the movements were checked
Pradeep,
after.
next one. What should be the position of KVS? What should be the position of tension band? How do you position? Is it the correct position? Yeah.
First of all, is it anatomically reduced or not? There is significant gap.
There is a gap and two small fragments. So probably without KOS, just tension band wire would have been sufficient. But anyway, should go through.
On the table, you must have seen that there is a continuity of the posterior cortex.
Yeah, problem.
It has been reduced because there is a good contact
Contact,
with
yes.
the posterior cortex. And after the towel clip has been applied, after passing the KYS, if you check it on the CM, then you know whether it is anatomically reduced or not.
So it's not. So they should cross the.
That principle has been applied. It has crossed the anterior.
And you generally you withdraw a little bit before you bend, and once you bend, push it back. And here, of course, so how it works, how, so you, the principle is, when do you move the elbow or immobilize the elbow following tension band bend?
We have to move, sir.
Mobilize them. So what happens when you mobilize? What happens at the fracture site? Does it
will
get
compress-
distracted?
No, sir. Distracted force is
The
completed
principle
into.
is, because the wires are anterior, so it gets by contraction of the triceps, it gets compressed. It should, if it is done properly, it should get compressed at the anterior surface. Okay.
Sir.
Sit down.
Sir, 59-year female with the closed distal third shaft fracture of left femur. The
Yeah.
spiral fracture. Sir. Had an
Extending this still, okay, good. Not MIS, completely open.
Yes, sir.
Difficult to reduce.
Yes, sir.
Okay. Next one.
72-year male with intertrochan fracture of right femur, Baden-Griffin type 2, sir. I have done close reductional fixation with long PFN for right femur.
So always do. I think long PFNs are better than short ones.
Yes.
Okay. Go back. So, is it happy or what else is there? The next one. How do you assess post-op X-ray? Because they're very common fracture, common problem. How do you assess it? Huh? Reduction. Okay. Is it satisfactory? Reduced? You're happy? Where is the gap? Here. Do you think it will collapse after weight bearing? So varus position is not acceptable. More varus collapse. Valgus is acceptable. Nowadays, anatomical reduction have superior results. So if you are not happy with the reduction, you can reduce the lesser trochanter. Lesser trochanter is important part. Put a circular wire. An entry point is okay? Where do you enter? But this one? Piriform fossa or
Medial to the tip of.
medial? Yes, medial. Okay, go on. Sit down. Next one.
70-year male with intertoken fracture of right femur, sir.
Mm-mm.
Biden Griffin type 2, sir.
Okay.
This close reduction, internal fixation with the proximal femoral nailing force.
Short one. Why short one?
Stable.
Probably.
Because of bending on the.
Angle is very bow.
It's bowing is present.
That's a justification. That may not be your intention, but I think it's justified here well. Okay, next one. Long. Long. Right, okay. So which is better?
Long is better, sir.
Long is better.
What is the advantage with this?
Because
Less radial.
Less?
Exposure.
radiological exposures to the for fixing the distal screws. There no we can do it free-handedly, sir.
Less radiation.
Less radiation.
And generally it doesn't penetrate the cortex.
The 48-year male with closed middle third shaft fracture of right femur and grade 1 compound proximal third shaft fracture of right tibia, sir. The floating knee diaphyseal types.
Okay.
I done close reduction internal fixation for the island for femur and open reduction internal fixation with plating for tibias.
Any comments? Anybody? Divyana? You happy? So what are these holes?
For polar screws. For
There is a breach in, there is
for
anterior
nailing,
slit
sir.
to prevent collapse. We have
Yes.
Guide wire is going, sir, but nail, when paused nail, it will go touches the cortex, sir.
You put it for guide wire and nail.
Nail is going, sir, first.
Put it guide wire.
Guide wire.
As the guide wire. You should position the guide wire. Moving a nail with a screw is difficult because already track is there. So when you put the guide wire, you want to move the guide wire, then put the polar screw. Okay.
Now what is the plan that you are going to make before proceeding for surgery?
first we have to fix the femur, followed by
Which bone first?
Femur first.
the femur first.
Vastana.
Femur has to
Femur
be
first.
stabilized first and followed by tibias.
Tibias.
Position of the patient. Don't we think of the position of the patient for any surgery?
Yes, supposition is.
Is it on the fraction table or
Traction table,
Traction
sir.
table, sir.
With the slab to the leg, yes, sir.
fraction table with a slab to
Leg for only
For,
to
leg stabilization we have
slab
yes.
What did you do for
on the table?
First we have fixed femur, sir, with the slab in the below knee slab, sir.
So does it not encroach onto the fracture femur surgical area?
so not above the knee, sir.
Below knee
Below
slab,
knee
sir.
was
Below knee only. How far do you clean the limb to make the field sterile for putting the distal locking screws? These are all practical points. It is going to get contaminated if it is a below knee slab.
because it's very close to the
Very,
Yes, sir.
very close. For femur distal locking, you have to clean the limb almost up to the ankle. No slab, you can just leave it because it is a stable fracture, it may not get unduly displaced. No slab.
if it is very unstable, you can put temporary external fixator. Just hold it. Maybe 2 pins. Okay.
55-year male with a 10 days old closed distal and both bone fracture of left legs.
Okay.
No intraarticular extension.
No, sir.
Then a CT scan. CT scan is done.
Done.
There is a malleolar fracture,
Medial
medial
malleus and lateral malleus fracture, sir.
malleus, there is a vertical fracture. Is in fact an ankle fracture rather than a distal both bones leg. It
That's
is the lateral
abduction.
malleolus is at the level of the joint line, almost at the, it is an adduction type of injury. Supination.
Adduction, yes.
Supination.
So vertical fracture of the medial malleolus, almost
And
transverse fracture of the lateral malleolus at the level of the joint line. Any posterior malleolus
No, sir.
appears to be intact.
Intact.
Yes.
It's a true supination adduction. So don't call it as a
Distal.
both bones leg fracture. Yes.
We have done CT, sir.
What was the need for CT? You were suspecting intraarticular extension.
Yes.
Sometimes to know whether
Yeah.
there is a posterior
Posterior.
malleolar fracture, rule of trimalleolar fracture. If there is a fracture in the posterior malleolus, you need to stabilize that also.
Okay.
Otherwise, it doesn't require a CT.
We have done open reduction internal fixation with plating for left tibia and fibula, sir.
Okay, looks good.
33-year male with a grade 2 compound distal third half fracture of right tibia, sir. So,
Fibula is intact,
yes, sir.
and there is a only tibia. You have to make a specific mention.
Hmm.
Fibula is intact. Sometimes we miss the fracture at the level of the neck.
These
Fibula is
X-rays, you see, not splinted, just sent for X-ray. But I think we should go with the patient because radiographer, they don't know. There is no splinting, and there is no true AP, true lateral. Assist them, explain to them, or train them. Any compartment syndrome?
No, sir.
It's only abrasion, is it?
So it's a deep abrasion.
Okay.
It's like a technically compound fracture.
Oh, this one and this one. What was done?
A close reduction fixation.
Go back. Wound is very small, insignificant. It dries up in about a week or 10 days time, by which time the whole swelling of the fracture site also may get grossly reduced. Undisplaced anatomical position. Why fix it?
What's the advantage of
You
fixation?
have to justify.
So because of the comminution.
Community is much more invited. It heals faster. The two metaphyseal section.
Almost undisplaced, yes. But advantage of fixation is early mobilization. You can make them walk, and joint mobilization early. But there is a, what is that, scope for, what is the non-operative treatment. You can put a good plaster because distal one, you can put a PTB and probably
You can start with a
with
sarmiento
sarmentoplasty, yeah.
below knee, PTB cast, and make them walk early at the end of 3 weeks. Because the fibula is intact, it is not
Well.
going to get displaced or angulated. That is the ideal case for management
fine.
for with Sarmiento.
Oh,
yes. We have done close reduction internal fixation with ILNs.
Recently he passed away, few years back.
Yeah, really, okay.
21-year male with grade 1 compound both bone fracture of right forearm, sir.
Okay.
The no DNVD, sir. We have done open reduction fixation with plating for radius and ulna. So
Okay, next one.
So 15-year female with a 1-week-old closed middle third shaft fracture of the left humerus.
15 year.
Yes, sir. We have done plating for the left humerus, sir.
Exposed radial nerve.
Yes, sir.
That's
It
a radial nerve.
corresponds with the it corresponds with the second screw, second proximal screw, sir.
No radial nerve palsy postoperatively.
No, sir.
Next one.
Is there a need for surgery for the fracture?
We can apply U-slab. It might.
Go back to the original example.
We can apply U-slab and
How can I
uh, post.
not a fully skeletally matured,
Sir.
nearing skeletal maturity. Bone blood supply is to be very good. There is a vertical split in the distal tract.
Sir.
Can you notice that?
Yes, sir.
Was it noticed on the table?
Yes, sir. Yes, sir.
Almost going up to the olecranon fossa. There is a vertical split.
It is not extended up to olecranon fossa, sir. It's nearing almost 3 centimeters.
Almost up to the fossa.
Yes, sir. Almost up to the fossa.
How to manage conservatively? No radial palsy.
No, sir.
Is radial nerve palsy with fracture humerus an indication for surgery?
Yes, sir. We have to explore the radial nerve.
Always.
If there is a radial nerve entrapped between the fractures.
Whether it is entrapped or not. You can't judge clinically or radiologically or even by an MRI. Okay. Yes, to some extent. If it is an iatrogenic, it may need exploration. But spontaneously, most of the times, the radial nerve damage is neuroproxia, which is going to recover on its own over a period of 4 to 6 months. That is the time that you should wait. 87% of the radial nerve palsies treated conservatively are going to recover fully, extending over a period of up to 6 months. So you should not be in a hurry to explore them. Almost all, except 10 to 13% of the palsies will not recover, which may require a subsequent management. So, is it acceptable position or not? This fracture is going to heal 100% without any hesitation. How are you going to manage this conservatively? Is it possible or not possible? How? So is this not angulation not acceptable? So anterior angulation or lateral angulation up to 20 degrees is acceptable. Okay. Rotation up to 30 degrees is acceptable. And shortening up to 3 centimeters in adults is acceptable, which does not produce significant functional disability or cosmetic deformity. These are the guidelines for less than 20 degrees of angulation, less
less than 3 centimeters of shortening.
Shortening of 3 centimeters or can be accepted, and these heal in about how much time does it take? Close to take
4 to 6 weeks for
4 to 6 weeks, too short.
3 months.
8 to 12 weeks. For the first 2 to 3 weeks, you give a U-slab or an arm chest bandage. Why there is a lateral ambulation so much like that? Proximal fragment, there is a powerful deltoid. It tends to pull it into abduction.
Abduction.
That will cause ambulation at the fracture site. So undo that. When you are putting a U-slab, mold it laterally till the slab sets. You have to keep it pressed so that the angulation is corrected. And the magnitude of the angulation can be corrected to a greater extent by molding the slab laterally and then put an arm chest bandage so that the movement of the shoulder does not permit re-displacement of the fracture. For first 3 weeks,
Sir.
then use a sterniotoplaster or a brace which extends right up to the acromion, which can still permit shoulder abduction and elbow movement, so that the post-traumatic stiffness can be avoided. That is the conservative management.
Posterior plating or anterior lateral plating?
Posterior.
How many distal, how many proximal?
Proximal 3, sir. Distal 4.
Okay, next.
68-year male with 20 days old intertrochanteric fracture of the right femur. This is Boyd and Griffith type 2, sir. We have done close reduction internal fixation with proximal femoral nail for the right femur.
Mm. 16-year male with a closed middle third shaft fracture of right femur.
Is the X-ray normal? Why do you keep quiet? Is the X-ray normal or abnormal?
Abnormal exposure.
The whole pelvis and the femora are appearing sclerotic. Is it the technique of the
X-ray.
X-ray?
Overexposure.
Huh?
X-ray.
And compare with the femur thigh X-ray. This lateral view appears to be near normal. That is the technique of the X-ray technician. It looks like a osteopetrosis.
So close reduction internal fixation with ILN for right femur. Sir. And,
You have produced a dystrophin of nearly 5 millimeters.
yes, sir.
Will it go for a routine healing period, or will it get delayed union or non-union?
Maybe delayed union, sir. We have planned dynamation and
Dynamization tarvata.
after 6 weeks. Maybe.
2 months, sir.
On the table?
After 6 weeks.
2 months tarvata. After 2 months, 6 to 8 weeks tarvata.
6 to 8 weeks. Yes, 6 weeks is ideal period. By that time, at least some sign of
Callus.
fracture healing should be seen. Callus should be
Attempted
seen.
callus.
Bridging callus should be seen.
Yes.
Otherwise, it is likely to go in for non-union. Okay?
This is on fracture table or lateral up? Left up or right up?
Sir.
On fracture table.
What do you do on the table?
Yeah.
When you notice a
Gap.
It is nearly 2 mm, it is acceptable.
Acceptable, yes.
If it is more than 2 mm, not acceptable. Can you do anything on the table after putting the screws?
We
Yes.
have to fix
Dog.
we have to fix one end and attempt for docking.
One ante upper or lower? Who
Sir,
will decide on that?
After proximal.
proximal nunchi we can.
Proximal? Make a complete sentence.
After fixing proximal screws, we have done docking. Otherwise, one more method is after fixing distal.
You have fixed the proximal
Yes.
locking.
Yes.
You also fixed the distal locking. Gap is 5 millimeters or even 10 mm. If it is 10 mm, it is surely going for non-union. So you said that proximal locking will be done. That is the first one that will be done.
Yes.
Okay?
Yes.
You have done, and you have noticed the gap at the fracture site before distal locking. What do you do?
How do you dock?
Traction
How do you
release.
dock the fracture site?
Release the traction
Release the traction.
and
We have
dogging.
to push it from.
Who will push?
Dogging.
You have released the traction.
Yes.
How do you reduce the gap? You have to remove the foot plate. Disengage the foot plate. Try to keep the knee in full extension by the surgeon, and then somebody will thump it on the heel so that the force will be transmitted. But however well you thump it or hit it, the gap is not going to get reduced so easily, because the nail is already there in the bone. That will prevent it from getting reduced, because the tip of the nail is in the hard, especially if they are very young individuals. The nail cannot be driven down into the distal femur. You will never be able to reduce the gap. The better method is
Distal.
remove the proximal locking, then do the distal locking. Keep the jig as it is. Take a slotted hammer and try to pull it out so that the distal fragment gets opposed with the proximal fragment. You can use so much of force, but the thumping with the hand is not, we have tried several times, is not going to alter the gap.
Yes.
That is the easiest method. Don't hesitate to remove the proximal screws. You can reapply it again at a different level. Okay?
Okay.
And if still there is a little gap, don't put the static screw in the proximal locking. Okay? Only keep the dynamic
Dynamic.
screw.
And other one is you need not go to the bang from the heel. You can just have the control at the knee joint. Milky procedure. Just put. So sometimes it depends on the distal length. So free or not, because most of the time the medullary canal is wider in the distal part compared to the isthmus. So it depends on the fixation. And yeah, I pin 2 minutes. Can I finish it?
50-year male with closed distal third both bone fracture of right legs. Open reduction tunnel fixation for with ILN for right tibia and open reduction tunnel fixation with plating for right fibula.
The nail is not going to the center of the distal fragment. There will be a valgus angulation at the fracture.
Valgus, lateral side. So which one is fixed first? The fibula or tibia?
Fibulas.
Why?
To maintain the length.
To maintain the length, inka? Only length.
Only one
Align.
screw is there in the distal fragment with inadequate stability.
That too, the screw is medial to lateral.
Okay.
Can it?
Such fractures do need external immobilization at least for 4 to 6 weeks.
Yes.
Prevent collapse.
25-year female with closed lateral condyle fracture of left humerus.
Anybody else have a comment on that?
Sorry, capital lumbar fracture more likely.
Capital and fracture.
Yes. This is the
Posterior surface of the lateral condyle appears to be intact.
yes. This is anterior capital lumbar.
See that in axial cuts, very very clear. A true capital and fracture. Yes.
Open reduction internal fixation with screws, headbutt screws.
Anterior approach, posterior approach.
Approach, anterior approach, posterior approach, or Cocker's approach.
Lateral.
Uri Nishan కేసుపోలే కేసుపోకుండా
Lateral.
Ah.
Cockers.
Who went for the case?
Preferably, it should be fixed from anterior to posterior so that it achieves compression and rigid fixation. There is also a method whereby we can make a very small incision posterior. The lateral condyle is a subcutaneous bone layer. You don't need to expose the joint, and then pass a partially threaded cannulated cancellous screw from posterior to anterior, which gives a lag effect. Lag effect achieves compression at the fracture site. A similar effect is achieved. But this is always a preferred method because it gives a better fixation than the posterior.
74 female with a closed distal and fracture of the left femur with no intra-articular extension, sir. Intraoperatively, there is no extension, sir. That's a mistake here. Intraoperative,
No extension.
no, sir.
Sure.
Sure, sir. It looks like an artifact, but there is no intra-articular extension.
So until proved otherwise, you should have to think that there will be always intra. CT is done.
No, sir. CT not done, sir.
So do you call this a supracondylar fracture or distal third femur fracture?
Distal third.
What is the difference between distal third and supra?
People, the
74.
elderly people, they have relatively low violence injury. Unlike
Osteoporotic.
young adults, the hard bone, it requires considerable violence. Elderly people with gross osteoporosis, with the trivial injury also they can sustain distal femur fractures. There may not be articular extension. Yes.
We have done plating for the left femur, sir.
Joint was exposed. Have you seen the articular
Yes, sir.
fractures?
We have seen, sir.
No
No extension, sir.
Because she is a very old woman.
74.
74, sir.
Supracondylar fractures are common in elderly without intraarticular extension.
38-year male with a closed undisplaced fracture of the left patella. It's a stellate type, sir. Multifragmented. CT was done, sir. Doing this one.
There is also one more point. When to call supracondylar fracture, when to call distal femoral fracture. The trans-epicondylar width from the joint line, that area comes under supracondylar area. If you go to the Rockwood Green, they say 10 to 15 centimeters of distal end of the femoral fractures. comes into the group of supracondylar fracture. That is not acceptable. Some people are 7 feet, 6 feet, 6.5 feet. Some people are 5 feet, 5.5 feet, and all the width of the condyles of the femur is not the same.
So we have done circular wiring for left patella, sir.
Does it require surgery?
Cylindrical cast can be.
Look at this patient. Who has seen the patient in KJ Reddy? Nobody has seen. And the patient went straight away to OT.
First unit, sir.
Transepicondylar width.
Have you seen the patient?
No, sir. I wasn't there at the time of admission. No, sir. I wasn't there.
In the OT.
Yes, sir.
Because you will be always in OT dress.
Transepicondylar width.
Extensor mechanism is intact.
Sir.
It is practically an undisplaced fracture. This is due to direct trauma.
Yes.
If the extension is full, that means extensor mechanism is
Intact.
intact. Extensor mechanism is intact. You can put a cylinder cast for 2 weeks,
Sir.
by which time the soft tissues heal. The parapatellar retinacula and the retinaculum over the anterior surface of the patella will be intact here. It is the bone that got comminuted, and all fragments are in good position. You see the CT scan. There is no articular step. Go to the CT scan. Put the sagittal plane. Zoom it. In the center field. Zoom it. Zoom it a little bit, where the full width of the patella is seen. See, there is no articular comminution. That is 100% congruent. Do you find any irregularity in the articular surface?
No, sir.
No.
Unda?
Yes.
No. Skyline view, CT views, sagittal films.
There is no indication for surgery here at all, except for Arogyasri.
Arogyasri రాదు, sir.
Isolated patellar fracture won't get. Clavicular fracture won't get. Coding won't get.
What is the post-operative regime?
We had to movement, sir.
Patellary.
So we have to continue movements. Mobilization, yes.
Mobilization. Only advantage is that otherwise it's a surgical procedure, and the metal prominence, patient may not cooperate, and you have a surgical incision, dissection. For the soft tissue strip, patella was exposed.
No, sir, not exposed, sir.
Exposed.
Not exposed, sir. Only the skin is incensed and
Circumferential wiring. Circularized wiring. Schwacker technique.
Subflage wire is different. Circumferential wire.
Wiring is different. But what is this? What is this?
This is circumferential.
Circumferential. Go back. ఏం రాసావు?
నేను circular.
అది విషయం. అది విషయం. అది గొళ్ళెం వేసి తప్పకపోతే ఎట్లా సార్? అది పెద్ద గొళ్ళెం, అది చిన్న గొళ్ళెం. అది చేస్తారు. కానీ
28-year female with closed middle third, lateral third, shaft fracture of right clavicles. Comminuted and more displacement is this. Then open adduction tunnel fiction with plating for right clavicle and interfragmentary screw also. This This is a case for discussion, sir. 66 years male with 7 months post-op follow-up case of intertrochan fracture of left femur with PFN, sir.
X-ray is very poor, we are not able to judge anything.
Zoom the image, only image zoom saying.
In such a case, you have to ask for the hip AP view, not the entire femur.
Yes. This after 3 months post-op, he fell slip. History of slip and fall, and came
Is the fracture
to
healed or not healed? Is there a fresh fracture or the old fracture?
maybe.
Membership ఉంటుంది కదా? అదేంటి?
This is 3 months post-op, sir. This is a fresh
7 months
presented
post-op,
7 months.
3 months post-op అప్పుడు ఏం advice ఇచ్చారు?
We advise admission and screw.
Is it Z effect or reverse Z effect?
Z.
Z effect.
This is the pre-op case, pre-op X-ray, sir, and immediate post-op X-ray, sir. This is.
Why the implant has backed out?
He is given after 3 months. He is given history of slip and fall.
Mobile premature weight bearing
Yes.
has backed out. The screw has backed out. Okay.
And now the plan may
Fracture read చేయని ఎంత ఏజ్?
66 years.
66. Age matters when you are deciding about the management. By redoing the fixation,
Yeah.
it again fails. The fracture line is almost vertical. There is a shearing force. That is why it has failed. You have to compression. You can preserve the head. There are two elderly. It's looking like a basal fracture.
Sir,
Looking like a basal fracture. And some calcar also appears to be intact. Where is the immediate post-op X-ray?
this is
Zoom the images, sir.
It is supposed to have united very well.
Post-op. Can you have the maxi zoom? Maxi zoom.
Is it truly a basal fracture? So it behaves like an intracapsular fracture, but management is like an extracapsular. Yes. Whereas the neck shaft angle has been reduced here. Because the distal screw is the one that will be fixed first. When you are trying to achieve compression, it tends to bring it into varus because it is trying to close the gap. So you are not supposed to remove the proximal guide wire. You have to put a derotation wire in the proximal part of the neck so that it doesn't allow varus collapse.
So reduction, yeah. So retention should be maintained till the fixation is over, because sometimes the guide wire comes on the way. So people, yeah,
Very well without any problem.
yeah. Sometimes I think.
No comminution, basal fracture, reasonably good vascularity. So the other option is the valgus osteotomy,
osteotomy.
and
variable angle locking compression plates. That is will give us better correction. Eleven ten.
Good morning, sir. This is a 55-year-old female with intertrochanteric fracture of right femur. Body grief type 2, sir. We have done closer direction internal fixation with the proximal femoral line. This is 88-year-old female with intertrochanteric fracture of right femur and 4-year-old intercapsular fracture of left femur. We have done closer direction internal fixation with the PFN for right femur, sir.
So 25-year-old male with intracapsular fracture of right femur with ipsilateral middle third fracture of the clavicle and Boxer's fracture in the right hand. So you've done close reduction internal fixation with boxers fracture.
Head or neck?
Neck.
Head unnaya? Very
Neck.
good.
So you've done close reduction internal fixation with CC screws by BDSF technique for the femur, ORIF with the plating for clavicle and K-wire fixation for the metacarpal fracture.
Go back to the metacarpal fracture.
Metacarpal fracture.
Yes, sir. Yes.
The
36.
angulation has been corrected to some extent, but
Yes,
still there is angulation,
Yes, sir.
dorsal angulation, and appears to be rotation also.
Yes, sir.
There appears to be rotation also.
So it's a retrograde technique or antegrade technique?
Proximal to distal. Boxer's fracture. That's it. Commonly seen in. Yes, sir.
Up to 30 degrees of angulation can be accepted for the fifth metacarpal
Yes, sir.
neck. The only thing that you need to take care of is rotational malalignment.
Yeah.
Did you check it after the K-wire has
Yes, sir.
been applied?
Checked, sir.
How did you check?
They check the extension and flexion of the metacarpophalangeal joint.
Whether there are full range of movements or
We wanted to see if there's any displacement occurring at the fracture side.
so for the stability under C-arm.
Yes, sir.
There is rotation, yes. What is this? What do you call this? What do you call this?
When you close the fingers, you have to point towards the styloid
Styloid process. Radius or
scaphoid towards the
there are two styloids.
radial styloid, sir. Towards the radial styloid.
Radial styloid.
ఇక్కడ ఉండేది ఏమన్నా? అక్కడ ఏం ఉంటుందా? ఉంటుంది. What bone is this? Which prominent carpal bone? What is this bone?
Scaphoid.
years-old post-op case of right proximal bone fracture with implant in situ. It's a 12-hole buttress plate, sir. We've done implant removal. So 30-year-old female. Sir. Slightly varus. Varus.
In APU, there is apex medially. The long axis of the proximal fragment and the distal fragment, there is nearly about 15 degrees of angulation. You take a plumb line from the center of the knee joint towards the proximal fragment and long axis of the distal fragment. Then measure the angle on the X-ray. That gives the magnitude of the deformity.
Yes.
Apparently it looks straight. And there is a increase in posterior slope. So it's nearly 10 degrees.
Full length, you have to show the ankle joint also.
Before implant removal.
What is this screw?
So there is a mall union. Okay. Must have been fixed in that position only. Okay.
You have to show the knee joint and ankle joint. Both you have to show. Ledu.
Okay, next.
It's a 30-year-old female with closed supramalleolar fracture of the left leg. We've done open reduction internal fixation with plating for the fibula, sir. And because we achieved a good reduction for the tibia, we didn't use any fixation. We just applied a below knee slab.
Okay, good. But 2 KYs through the medial malleolus to the lateral cortex of the tibia, probably you can mobilize the joint very early.
Yes, sir.
You don't need the open reduction. 2 KYs will give good stability. So plastic can be removed earlier, maybe after 3 weeks.
Yes, sir.
But still weight bearing, total weight bearing is very careful. How much weight transmitted to the tibia and fibula?
1/6 through fibula.
Mike.
1/6 of the weight is transmitted through fibula.
What are these 2 views?
AP and lateral, yes. Marty, sir.
This is Martis view.
Marty, sir.
In AP view, there will be overlap of the fibula
Yes, yes.
on the lateral margin of the tibia at the syndesmotic level by about 10 to 15 millimeters. So this is the Martis view.
Yes, sir.
And if it is anatomically reduced, the lateral margin of the talus should correspond with the lateral margin of the
Tibia.
that is called incisura.
Yes,
That is very important in ankle fractures. Next week closer. Fortnight. Yes. Or even before also they can do it. అప్పటికప్పుడు వచ్చింటే మన అయ్యే పని కాదు. Do it, huh? ఇక్కడ ఇదే బెటర్. Probably that is better to do it here.
Yes, sir.
Instead of the seminar copy.
Yes.
Seminar బదులు అది పెట్టండి.
Yeah, better, sir.
Journal club బదులు. That is ideal.
Monday. This Monday.
All our papers are posters. Some posters,
Some papers.
papers.
Sir will be coming on Tuesdays and Thursdays. ఈజ్ కమింగ్ ట్యూస్డేస్ లేలే ఈ ట్యూస్డే ఎగ్జామ్ ఉంది సార్. మండే ట్యూస్డే ఎగ్జామ్ ఉంది కదా. మండే ట్యూస్డే ఎగ్జామ్ తర్వాత సార్ all the people who are presenting for Tosagan, so immediately after the exam on Thursday you have to present a rehearsal at the seminar hall.
So every college has to give 3 candidates as a team.
మన దగ్గర పార్టిసిపేట్ మన కాలేజ్ నుంచి ప్రిలిమినరీ అండ్ ఫైనల్. Final years are not appearing. Quiz competition. You are participating, not participating? Participating. You will decide. ముందే పంపించాలి. కమిటీ మెంబర్. రాఘవేందర్ రథస్వామి మీరు కూడా రండి సార్. సో ఇఫ్ యూ రండి కమన్ సార్.